sternum directly?
7.
7. And then I have ribs 8, 9, and 10 that false ribs that indirectly connect to the sternum. And then I have ribs 11 and 12 that float, that do not connect to the sternum, correct?
Yes.
And then I have vertebrae. How many ribs connect to the vertebrae? All 12. Where's the vertebrae?
Trick us with that one.
Where's the vertebrae? Back here. That was the question that people got wrong the most on that previous test. You were so focused on sternum and how many, okay, that's one, this one, this one. And the question didn't ask about sternum, it asked about thoracic vertebrae, the stuff in the back, right? All 12 ribs connect to the back. And I may have asked a question about something on the front. I don't remember exactly how I worded some of the ribs, maybe just their names, false ribs or true ribs or something like that. But yeah, the one about how many connect to the vertebrae was the biggest one that folks got wrong. Anyways, we have the rest of this week, and then we'll look at that test on Monday and let you guys agonize over what you put. All right, so today, drum roll, this is when we actually get to talk about therapeutic stuff. And what a more perfect topic to discuss than airway management. Again, being a respiratory therapist, working with the airway. And so of airway management, and again, I'm breaking this chapter down into 3 parts, but the chapter opens with suctioning. That's what everybody wanted to talk about, especially after lunch. Suctioning, and suctioning mucus and secretions up from someone's lung or airway. So, a few things here, and I also will say this, I am in the chapter verbatim with how the chapter kind of flows up to a certain point, and then I'm going to dance around the chapter a little bit, probably more so with part 2, part 3. It's just, they discuss certain things in the chapter, and then they talk a little bit about something, and then they go on to something else, and then later they kind of finish up the something they started. So I'm going to try to put things, in my opinion, where they go, in the proper order or placement, if you will. But anyways, I am starting here with the beginning of the chapter on suctioning. So we may suction patients for various reasons. Obviously, a patient that has retained secretions, airway obstruction perhaps, because of blockages of secretions, foreign bodies. Foreign bodies could be mucus still, could be food, etc. False teeth, we see sometimes people aspirate all kinds of weird, obscure things. Patients who have difficulty clearing their own secretions. Those may be patients we have to actually suction and assist them in the removal of their own secretions. And then the last one here, a sputum specimen. If we need to get a sample of a patient's sputum, because we're supposed to send that sample to the lab so they can test it, analyze it, see what bug or mycobacterium is growing in there, then we'll have to obtain a sputum specimen. So kind of 3 different reasons for us to suction a patient. Again, when we suction, we are applying negative pressure or vacuum type pressure to remove those secretions that we're trying to get out of the patient. We can suction the upper airway, meaning the oropharynx, basically just out of the secretions that can pool just in the mouth. We can even go down into the lower airway, for example, the trachea, even the bronchi perhaps. We will not do, and I'll refer to this perhaps, suction in the lower airway. We will not do tracheal suctioning by placing a catheter or anything orally through the mouth, because the patient will perhaps gag and the fear of aspiration, that sort of thing. So when we do have to suction the lower airway, we're generally going through the nose, tracheostomy tube if they have a tracheostomy tube, or the endotracheal tube, the breathing tube, which we'll talk about a little bit more today. Secretions, fluids that are pooling in the mouth or the oropharyngeal area, we can use what we call a Yankauer suction. It is a hard plastic pictured here. That is something, please remember, and some that work in a hospital are accustomed to this for patients, but please remember this hard plastic piece, we are not sticking down someone's nose. We're not pushing that down the back of the throat, unless you really like a mess. We're not pushing that, but that's just simply for oral secretions that build up in a patient's mouth. And all of this stuff, all the equipment we're going to talk about today, we will see Friday in lab, and you'll get the opportunity to kind of play with it and have hands-on with it. All right, a suction catheter. I'll call it a flexible suction catheter because it does need to kind of move and manipulate as we advance it down into the airway. I will say this is considered sterile because we are introducing this catheter into the body, so it needs to remain, it is sterile when we open it up from a package, and it needs to remain sterile. If I was to open it up from the package and oops, I accidentally set it on the table, a bedside table, or I touched it with my non-sterile hands, I've just contaminated the catheter and now it is not sterile anymore. This catheter is used to suction down into the lower airway, the trachea. Can be inserted through the nose or through an artificial airway, like an endotracheal tube or tracheostomy tube. The catheter itself, so this is the suction catheter itself. There is kind of a thumb port here that when this suction catheter is connected to vacuum tubing, and now suction is constantly being applied, when you occlude or put your thumb or even finger over this port, now you will have vacuum at the end of the catheter. But if you don't cover this over, even though there's vacuum occurring here, you're not going to be able to really suction anything from this port because all of it's being kind of pulled into this thumb port. You block that passage, then you will have suction being applied right here at the end to the tip of the catheter. They do have, and we typically will use, a suction catheter kit where the catheter itself is already inside of the package, sterile and inside that package or inside that kit. Additionally, inside that kit, there's going to be sterile gloves that we'll go over in time the process on how to put on sterile gloves. Because if I just open this package and the gloves fall there onto the floor or onto the table even, or the patient's bed and the bedding, now I've just contaminated those sterile gloves that are supposed to remain sterile throughout this procedure. May also contain a small kind of cardboard piece that we can put some saline or sterile water in if we needed to kind of vacuum or clear out the catheter if it gets kind of gunky or blocked up with mucus. All right, two primary techniques for endotracheal suctioning. That's simply suctioning through the trachea. Two techniques. One is referred to as open. And I will step back here for a second. What we're talking about here is perhaps a patient on a mechanical ventilator who they can't clear their own secretions very well because we have a breathing tube stuck down through their glottis and their vocal cords are wide open, so it's going to be hard for them to be able to generate an effective cough to clear secretions. So in this example, open suction means we actually disconnect the patient from the ventilator. We break the circuitry, we disconnect the ventilator circuitry from the patient so we can apply and put that suction catheter down that endotracheal tube. God bless you, down that breathing tube. Now I will say this, we do not like to do that because you disconnect the ventilator circuitry from a patient. Even though we're being very careful and practicing sterile technique, we introduce the opportunity for germs, bacteria, microorganisms to get in, and we see that increased incidence of VAP that I mentioned before in those situations where we disconnect the circuit. So open's not the preferred method. Sometimes we have no choice, sometimes we do have to do it that way. The other one is closed. In the closed technique, there is a suction catheter inside of a very specific, and I'll show you what it looks like here in just a second, a very specific, what we call closed inline suction catheter, where we do not have to wear sterile gloves because our hands will not exactly touch the suction catheter. It's inside of a protective sleeve, and our fingers will touch the sleeve, but it will not physically touch the suction catheter. And I'll show you what it looks like, and you'll see this on Friday as well. Here's an example of a patient with having open suction. Now this, we have to be careful when we do this. Obviously this gentleman has a tracheostomy tube, and I could pass that suction catheter down through the tracheostomy tube. I will say a couple of things here. the individual touching that suction catheter has to be wearing sterile gloves. Now, I didn't create this picture, I didn't create this image. I Google image searched it and came across this one. I thought, okay, fair enough, it looks right to a certain extent. They're wearing regular gloves, regular clean gloves. They're not wearing sterile gloves in this picture. But you will wear sterile gloves. Yeah, I saw a picture on it, boo, boo, hits. Perhaps I'm to the point now with technology, I could probably Photoshop and remove at least the purple color, because that's what stands out in my eyes. Those are just regular clean gloves, not sterile gloves. But nevertheless, you can see how their thumb is getting ready to go over this port. But here's the tricky part about doing this open suction. One, you're wearing sterile gloves. Your sterile gloved hand is the only thing that can touch that catheter to keep it sterile. But here's the problem we have, whether you're a student, whether you're a respiratory therapist, is when you advance that catheter, can my fingers touch their tracheostomy tube? No, because that tracheostomy tube is not sterile. So if I'm advancing this catheter, and every time I do it, I touch that tracheostomy tube and advance the catheter some more, every time I touch that tracheostomy tube and then I touch the quote-unquote sterile catheter, that's an opportunity. I'm introducing microorganisms to that catheter. And what am I doing? I'm passing it further and further down into the lungs, bypassing all of the patient's natural defense mechanisms for germs and microorganisms to get in there. So that's a tricky thing that you will learn in time. Okay, it's not impossible. Now, I will also say this, do you think your patients stay perfectly still each and every time you do this? That would be great if they did, but sometimes they don't. And sometimes they reach up and grab the catheter. Can't do that, sir. All right, let me get another one. Let me start over again, because they just contaminated their own catheter. Sometimes I need a partner in there, one of you guys, or you use me, and we just kind of help hold the patient's forehead a little bit. I don't mean we're putting them in a headlock so they can't move, but just to kind of stabilize them a little bit so they're not doing too much movement back and forth.
So if you're already putting it in there and they touch it and obviously it's not sterile anymore, you have to pull it out and
Yep.
then restart, right?
Dispose of it and open up a new kit. 6 kits later, finally you get the patient suction. Hopefully not, hopefully not. Don't want to waste resources. But yes, if that catheter becomes non-sterile, I cannot use it.
How do you get reinforcements before you open up 6 of those?
This is an example or a picture of a closed suction catheter. Now, the suction catheter is still here. Okay, it's still connected to vacuum tubing. There's actually a thumb control, not just an opening, actually something that you can depress and create vacuum, create suction. Now, if you notice the catheter, it's inside of this protective sleeve. Now, this sleeve is clear, so you can see the catheter. You do not have to wear sterile gloves during this procedure. I will say I'm still wearing clean gloves, the gloves I'm putting on as I walk into the patient's room. That is okay to touch the sleeve, but remember, we are not actually touching the suction catheter. I don't have to disconnect the patient from the ventilator. I can simply advance the catheter down their breathing tube, down their endotracheal tube, and apply suction and remove the catheter, and at the same time removing secretions. Okay, so a much simpler, easier, more effective system to suction all of those patients who are going to have to be attached to a ventilator. Now, what if the patient's not attached to a ventilator? Then, okay, we're probably not using this system. We're going to use something that may look like this, all right, the sterile suction catheter kit. All right, this, again, we'll go over this a little bit more on Friday, but I just like to give you pictures when I can. This is a person who's suctioning a mannequin, and they're using that closed suction catheter system. But I wanted to point out what their hands are handling or touching right now. They're advancing the catheter. They're putting the catheter inside of that endotracheal tube, advancing that catheter inside the airway. There is no reason, and you can't even see it in the picture, the controls over here, there's no reason to create suction yet. We only suction on the way out, not on the way in to the patient. So when you advance the catheter, of course, in the beginning, you're going, okay, that's the control, I can hear it. I hear the vacuum, I hear the suction. But there's no reason at that point, when you're advancing the catheter, to worry about having control over that piece. You're going to advance the catheter to its proper depth. We'll go over the depth here in just a second. To its proper depth, Once we're there and we begin to pull the catheter back out, now I can control suction. And every time I depress that button, suction's being applied, okay, on the way out. But here's a be careful moment. With their right hand, and I don't know how many right-handed people are in this room, how many left-handed people are in this room, okay. Doesn't matter, whichever hand is easiest for you to control, I would say use that hand. Now sometimes it does depend on which side of the bed you're on. You know, that makes a difference to me sometimes, whether I use my right hand or left hand, but regardless, when you're advancing the catheter, you're using one hand. The other hand, stabilize and secure, in this example, the endotracheal tube. Because you're the only one who has control of that endotracheal tube as you're advancing the catheter. When you apply suction and you pull that catheter back out, what am I doing, at least in this picture with my left hand? I am holding and securing that tube, as opposed to, let me pull it out this way. Because guess what could come out with that suction catheter? Their endotracheal tube, the whole thing. And I don't want to, quote unquote, extubate the patient prematurely, okay? So my left hand is always going to be securing the tube. Now the tube will be taped or secured somehow, but it's not 100% secured where it's not going to accidentally get pulled out, okay? So always make sure, and like I said, we'll go over on Friday kind of the steps to make sure you're doing that properly. Here we're applying suction again, only on the way out. You notice in these two pictures, they're holding that endotracheal tube with their left hand the entire time they're applying suction. Now there's a couple different schools of thought. When you apply suction, when you get that catheter down to the required depth and you begin to suction and withdraw the catheter, should you keep your finger depressed on that button? Remember, every time you keep that finger depressed, you're applying suction. And go ahead and pull and suction all the way on the way out. That's option one. Or do you think we should apply intermittent suction as we're pulling out? So there's suction, vacuum, and nothing. Suction, vacuum, and nothing every time you're doing this. Because every time I depress down, suction's being applied. Every time I let go, suction's being released. Do you think it makes a difference as far as what I'm doing or what I can get out if I'm doing intermittent suction or just straight continuous suction?
I've heard some people call it like the butterfly. It's like butterfly wings, like flapping, so you're going like up and down.
Okay.
That's my way to like remember.
I got you. That's fine. That's fine. Think it matters? Think it makes a difference?
Well, you wouldn't want, if you're doing that, I would think probably intermittently, because you don't want to pull stuff further down. You want to pull it out, correct?
Sure,
So
sure.
if it's suctioning, it could potentially suck stuff from above down as you're.
Well, it won't pull anything really from above, but things that are down, because remember, we're going through a breathing tube, the trachea, to our depth, which we haven't said exactly how deep we go yet, but to our required depth. And then as we're applying suction, pulling back out. Well, here's the school of thought. If I'm down into the airway, I am past the end of that breathing tube, and I perhaps am touching tracheal wall. If I apply continuous suction, I could agree I'm pulling out mucus, but what could I also be pulling out? Tissue, right? Tissue that's possible with continuous, just straight suction. That's why we kind of do intermittent, so I'm not grabbing a hold of a tracheal wall and kind of pulling on that. That's why we do intermittent. Now you will find out that some people will continue, once they get the catheter pulled back enough and you know I'm no longer touching the tracheal wall, I must be inside of the breathing tube, the endotracheal tube, they might then apply some continuous suction. So you'll see it done a slight couple different ways, and I'm not saying one way superior to the other. What you will find in time is maybe that's how they do it at hospital A, and they do it slightly different at hospital B. Both can be acceptable, both are okay, but it's a matter of, well, which house are we in and how do they want us to perform it?
Could you suction enough tissue out to like cause a big problem?
You could, and we'll get to the hazards, complications of suctioning, but trauma is one of the hazards and complications of suctioning, especially if we're aggressive when we suction, or we suction maybe too frequently. All that stuff could create issues.
Are there different suctions with like different levels of pressure? It just
We're getting there. We're getting there. We're getting there. Yep, absolutely. All right, so speaking of, thanks for the lead in. Speaking of the suction pressure, we will be setting it to a certain level depending on who the patient is. So these things, when we turn up, some are digital, some are analog, like this particular picture, where you can sit there and turn a dial and you'll notice the increasing vacuum pressure that's happening. Again, we can practice all this stuff in the lab, which is nice, because you really can't do a whole lot of quote-unquote practicing and see what it's like when you're in the hospital because you're working with a patient. So we can do that in the lab. We can set the vacuum to maximum and see what sort of suction that feels like just on our own palm, on our own hand, on our own arm, to see what that feels like. Think, that same suction could be applied inside the trachea. Do you want it pulling that much, set to complete maximum? Or is there maybe a little bit lower vacuum pressure number that we can do to still get the same benefit, the same effect as far as removing secretions without causing trauma or damage to the patient's airway? So, I say this about suction pressure. Whatever pressure it takes, keep it to the lowest possible level as long as we're still able to remove secretions. If I set it to a certain level and I notice, I can hear this patient has lots of secretions and I'm not applying enough vacuum, what would I suggest? Increase the vacuum, turn it up until you're able to get some secretions. Now, that's up to a point. That's up to a point. If we're talking about adults, or excuse me, neonates or pediatric patients, that pressure should not exceed 120 millimeters of mercury. That's a negative vacuum pull, negative vacuum pressure. If we're talking adults, should not exceed 200 millimeters of mercury. Remember those numbers, especially this Friday when we actually set up some suction to let you guys kind of get the experience of it. We'll set it to less than 200, and then we'll do the exact opposite and set it to 400, 500, just to see, so you guys get the visual to see what it looks like, what it feels like with that much suction. And I want you to remember that when it is time that you eventually do suction a patient, that you do pay attention to how much suction, how much vacuum you're creating to that inside that patient's own airway. Because I will say this, when we put a catheter inside the patient's trachea and we apply negative pressure, vacuum pressure, yes, I'm suctioning out mucus and secretions. True? What am I also removing? The oxygen that's in their lung, the tidal volume they just inspired. I'm pulling all of that out. I know our goal is the mucus, but we're pulling everything out. So we need to be mindful of that. And again, the more vacuum, the more negative pressure, the faster or more of that volume or oxygen we are removing from the patient's airways.
Is the suction on this regulator always turned on?
Not necessarily. They could be turned off.
Well, I mean, like, do we keep it on the whole time?
Good question. During the procedure, obviously yes.
Right.
Depending on the frequency of us suctioning, if it's a mechanically ventilated patient, I'm going to say yes, we're just going to keep it on. Suction's not being applied until I press that trigger.
Right.
So be mindful of that. So even though it's technically on at the wall, there's no vacuum applied until I press that trigger. But if it's a patient that we've had the suction once in the last 3 days, there's probably no reason to keep the vacuum regulator turned on. But just remember, because this can happen, get everything all set up, you're ready to go, and then you realize, oh shoot, can somebody flip that switch on for me? Because I have no vacuum. Right when you're all gloved up and you're ready to go. All right, so steps here for endotracheal suctioning. So suctioning down someone's trachea. Number one, patient should never, ever, ever, did I say that enough? Ever be suctioned on some sort of preset schedule where you're saying, well, every 2 hours let's suction, or every 4 hours let's suction the patient. I am not going to suction a patient on some sort of pre-existing routine schedule. You may see physicians write orders, suction Q4 hours. Oh, that's a nice suggestion, doc. But I'm going to suction only when what? It's indicated. Only when it's indicated. When there's a reason for it. Because it is a traumatic procedure. It is uncomfortable. If there's no secretions, why am I torturing my poor patient applying suction to them. All right?
I had a patient one time, he liked the feeling of it.
Absolutely, absolutely.
So he was calling like every 10 minutes for us to go in there and suction him, or like he tried to guilt trip someone when they walked in there to like suction him. And like, so all the nurses, the doctors, there's right there, every time someone walked in, he's like, please suction me, I haven't been suctioned all day. So we just started like writing it on the board.
How
the
frequently
time.
you guys are doing it?
We
Yeah.
were only allowed to do it every 6 hours, because
Gotcha.
it was like damaging him.
Right, okay, so now I'm not gonna use him as the example here, but a patient that does have lots of retained secretions, they will, I mean, yes, it's uncomfortable, but they will appreciate you getting rid of those secretions because they can't get rid of them any other way. Going back to your patient situation, I'd be curious that, especially before you held off doing it so frequently, were they getting anything out of them?
No.
Yeah.
No.
So that's something else. You know, buddy, there's nothing there. We suctioned you a little bit earlier. Okay, I'm listening to you. I can do my assessment. I can tell there's nothing there just yet, but we're not gonna just not do it. We'll come back and get to it when the secretions are building up. Now I don't know the situation there. Maybe that guy just liked the attention of people being in the room. But so only suction when necessary. Only suction when indicated. Look for clinical indicators. What do you think? How do you know if this patient right over here in the bed needs to be suctioned? What are some things you're gonna hear? Their breath sounds. So they may have those loose, moist, wet breath sounds that you will say, if you could just cough, if you could just cough well enough, you'd bring that junk up and get rid of it. But maybe you're so weak or so debilitated you're not able to take a deep enough breath and cough. So that's why we're here to help suction. You know, we can go and say the vital signs like oxygen saturation levels may be falling because of the buildup of secretions. Don't forget just simple palpitation. If a patient has lots of secretions, you could literally put your hand on their chest and feel the vibrations of mucus underneath their chest. I've had students before going, John, I think I need to suction. And they're listening, and they probably thought that too good to auscultate. You know, I'll just put my hand on their chest going, no, you're right. You know, I didn't need to necessarily listen for it, but I could feel it. I could feel it. Go ahead. And that's just another tip. Again, still, we need to document breath sound, so of course I'm still going to auscultate, but just hands on the chest to feel the vibrations of secretions they're not able to remove. All right, step number 2, this is assemble and check equipment. Now I stole this from box 37.1, which did I not write down the page number? Dang it, John. All right, but I did give you the list here, so everything that would be necessary to suction. You need a vacuum source. Okay, now every hospital room there is going to be a vacuum. Doesn't necessarily mean it's going to be connected. So you have to make sure there's a vacuum source. Now, let's talk about some of the emergency departments around. Now, a patient's room in the ED, it's going to have vacuum. And I think we may have mentioned this before, when it's really, really busy and you may have a patient where there is no rooms available, where does the patient end up? In the hallway where there is no vacuum, there is no oxygen outlet. We bring tanks with us, we hook the patient up to the tanks of oxygen, and if I need to suction, and again, there's not a room available, there is portable suction that we could take and bring to the patient. It does require electricity to be plugged into the wall outlet, or even a patient in the home that doesn't have the vacuum source like we have in a hospital. Again, they do make portable suction, portable vacuum regulators. The regulators, so we can regulate what that suction pressure would be. Somewhere to collect it, some sort of collection bottle, the tubing itself to connect to our suction catheters. Again, gloves, sterile gloves if we're doing the open technique, regular clean gloves if we're doing the closed technique. The sterile suction catheter itself, maybe the water cup if we're needing to clear the catheter. Of course, our regular PPE equipment. Oxygen, need to have an oxygen source available. We'll explain why in just a second. Pulse oximeter, that'll gadget that goes on the end of the finger, and what's that telling us? What's that measuring? Oxygen saturation, which again, when we're suctioning and we're removing mucus, and yes, we're removing their tidal volume, we're removing their oxygen, I'd like to know, how is my oxygen saturation handling the procedure that I'm doing. A manual resuscitator bag, again, things can go emergent here, where we do need to manually ventilate them, and then don't forget your stethoscope. All right. So we've checked and assembled. We have the equipment. Okay, we have the equipment. Now here's the catch. Here's the issue we'll have when we try to figure out, okay, what size suction catheter do I need? Because they do come in various sizes. The airway itself, units, is in millimeters of mercury. Or not millimeters of mercury, millimeters, sorry. Millimeters of mercury, it always follows millimeters, okay? So that tells us the diameter of the airway. The units are always in millimeters. Our suction catheters, they don't size them or label them in terms of millimeter size. They refer to them in sizes known as French. Now there's not an easy, there is a simple, but it's not such a straightforward conversion to convert from millimeters to French units, okay? Before we get to that, however, how big of a suction catheter can we place inside a patient's airway? Well, if I know the diameter of the airway, okay, and we'll go over how we know that here in a little bit. If I know the diameter of the airway, and I have a suction catheter, and I know the suction catheter's size, I'm only allowed to insert a suction catheter on an adult patient that is not more than 50% or not more than half the diameter of the airway. If I put a catheter in that, say, was 80% of the diameter of the airway, that's a massive restriction of the patient's airway. So we only insert a catheter that is at least no more than 50% of the diameter of the airway. If it's kids, it's a little bit more, 70%. Part of the reason for that is their airways are much smaller than the adults. You tend to need a little bit more room to be able to vacuum and suction. But I'm emphasizing here with the adults, that internal diameter of that suction catheter, or that suction catheter cannot be more than 50% the internal diameter of our airway. Now going back to sizing, okay, 1 millimeter is equivalent to 3 French. 1 millimeter is equivalent to 3 French. So multiplying the millimeters, the internal or inner diameter of that airway, by 3 will convert that tube size, or that tube internal diameter, into French. Simply multiplying it by 3, okay? Now we're not going to use the same size suction catheter because what's the rule? Has to be less than half, or can be 50%, but can't be more than 50%. So I will need to sit there, take the size in millimeters of my airway, multiply it by 3, and then I will have to cut that number in half. Cut that number by 50%. And I can do it one of 2 ways. You figure out what math works best for you. I can simply say, I'm going to multiply that number that I got by multiplying the size times 3. I'm going to take that number and multiply it by 0.5, 50%, and the answer I have will be the size catheter I need to use. Or the answer I get here, multiplying that size times 3, I just simply divide it by 2. The number is going to be the same. So it depends whatever works best for you. My example, we have an 8.0 millimeter endotracheal tube. What size suction catheter should we select? So what do I do to the 8? 3, that gives us,
The French for the airway.
but numerically, that gives us 24. And what do I do with 24? Cut it in half, divide it by 2, or multiply it by 0.5. On my example here, if you want to snap a picture of it, you're more than welcome to. My example, I use multiplying by 0.5 because that's how the textbook did it. But I know myself, I just simply divide it by 2. Or, like I said, cut it in half. It's okay, because I know sometimes the numbers don't equate to a nice even number like we have here. So if it was like 11.5, I'll go ahead and round that up and call that still a 12, because we don't have suction catheters that come in half sizes. Okay. But I know a question like this, which is pretty simple, straightforward, I know for a fact, whenever we test again, that's gonna be a question. Yes, Connor?
Is it best to always go for the maximum size available?
Yes and no. Yes and no. So, if, and we can debate, all right? If this is my endotracheal tube diameter, right? And please forgive me, I'm not gonna be exact here, I'm sure. If this is the size suction catheter I'm using, okay? That's probably less than 50%, but you get my general gist. If I increase it, and now I have a suction catheter that's say beyond 50%, the positive side, I'll probably be able to get more stuff out just because of the larger catheter. But now I'm really obstructing or restricting the flow of air, which is going to make it harder for the patient to breathe. So it's a double-edged sword, but we know textbook-wise should not be more than 50% the internal diameter of the airway. Go ahead.
Is it always best to go for like that 50%, or are there situations where you might want a smaller size?
Smaller size, gonna pull up less, have the ability to pull up less secretions. So I wouldn't say I'd rather err on the larger, nor would I want to err on the smaller side. Get as close as you can to 50% for the most effective suctioning without creating too many negative effects of this procedure.
And then with the pediatrics, you times it by 0.7.
0.7, right. And that one, probably, again, why I should get away from saying just divide it by 2, because if now we have a pediatric patient where the number can be 70%, that's a little bit harder to say divide it by 3, somewhere. No, just multiply by 0.7 to see exactly what size. So yeah, for the kids, it's gonna be a little more challenging. Again, just, you have to remember the number and remember how to do those steps. Okay, yes?
And I feel like once you like get in the field quite a bit and you memorize the ET sizes, you can kind of like correlate.
Oh, sure, because those things aren't gonna
Size
change.
with this,
Right,
right.
because those things aren't gonna change.
That way you can be like, oh, they have a 7.5, so I need a so-and-so.
Yes.
And you can just use that information
Yes.
for whoever else has a 7.5.
Correct, correct. But knowing the MBRC, when it's board time, they're gonna ask that question and be very specific and want you to make sure you select the right one.
So just to clarify, if it was a kid, it would be 8 times 3 equals 24, and then 24 times, or divided by 0.7?
It would, if it was a kid, where needs to be about 70% of the internal diameter, and let's just pretend it was this size tube, which is too big for a kid, but
Yeah.
let's use the math, and I get 24, I would have to times it by 0.7 and see what size that is, which in this case would probably be, I don't know, it'd be more than a 12. It'd be more than a 12. Right, so if it,
So how would
so
you- how would you
mathematically,
do 16.8?
if the answer was 16.8, I'll go ahead and round it up and call that 17.
But that would be making it bigger. though.
Slightly.
So then would you,
Slightly.
at that point, would you want to like make
Slightly.
it smaller? So
It's
you-
okay, slightly, slightly.
So then did we times the 0.50 or divide the 0.50? And this one, we times it either way?
Times it.
Okay.
Times it. Like I said, for myself, just personally, again, because it's 50%, I could simply take that 24, divide it by 2, my answer is 12.
Okay.
And that's still where I'm getting that number from. But you're right, if I'm using the points, if it's a kid, neonatal pediatric patient where I'm, again, 70% of the internal diameter is what I'm supposed to use, I can't divide it by a specific number. In that case, I'd say times 0.7
Okay.
instead of 0.5.
Gotcha, thank you.
Sorry for any confusion
No,
on
you're
that.
okay.
All right, so that was step 2. Making sure we have the right suction catheter, right? All right, so we have the right suction catheter. So before we apply suction, this is very important. Please remember this. We must pre-oxygenate the patient with what FiO2? And are you okay with me using the word FiO2? FiO2 stands for fraction of inspired oxygen. When I say I'm putting my patient on 50% oxygen, the FiO2 is 50%. If I say I'm putting this patient on 24% oxygen, their FiO2 is 24%. If I say I'm putting the patient on 100% oxygen, their FiO2 is 100% oxygen. So we have to. It's not a suggestion, it's not a tip. No, we have to pre-oxygenate that patient with 100% oxygen before we do this procedure. Again, not only are we removing mucus, what are we also removing from the patient's airways? Oxygen. And so the reason we pre-oxygenate them is to give them a little buffer zone, a little wiggle room, knowing I'm going to be suctioning some of that out anyways, but I'm still supplying them. So I'm not taking their, if they were just on room air, I'm not taking their room air and making it less by suctioning them. So always pre-oxygenate with 100%. That's an adult patient. With neonates, we are not as aggressive. Instead of putting them on 100%, we simply increase whatever they were currently on. We simply give them a little bit more, and we increase it by 10%. So if they were on, say, 30% oxygen, to pre-oxygenate them, I'll put them on 40%, not 100. Everybody okay with that? I know we don't know why just yet, but we haven't gone into oxygen therapy. I know some of you guys have started to talk about it with Desmond in the lab, but we haven't talked about oxygen therapy. That deals with one of the hazards of oxygen therapy, but we'll get to that in due time. Now we've done that, and again, I didn't say you had to pre-oxygenate them and they'll leave the room and go to lunch and then come back, 30 minutes later. No, I'm not leaving them on this 100% oxygen forever. 30 to 60 seconds. Some folks can say, well, I like to use 2 minutes. More power to you. That's okay. That's not hurting anything. Okay? But you're giving them a little bit of a boost of oxygen. So when you do suction, when you do remove some of the oxygen, you're not dramatically changing what's happening with their oxygen levels. So when we insert the catheter, there's 2 different acceptable ways to insert a catheter. Now obviously the catheter has to be inserted into the airway. That's fine. But this is, how far do we go? How far do I advance that catheter in the airway? And again, currently 2 schools of thought. Let me go ahead and do the one on the right first. Deep suction method. That's what you're probably going to see most often, is the deep suction method, which means you will advance that suction catheter as far as you can until you meet resistance, until you can't advance that catheter any further. So what do you think? I have an endotracheal tube in. You're advancing that catheter. You're adding more and more of that catheter to me. At some point, it's going to stop. You can't push it any further. What do you think? What do you believe we just hit? The carina. Very good. The carina. Now, when we hit the carina, that will stimulate the patient to cough. They will respond. And coughing is a good thing from the patient's perspective, because now they're bringing stuff up where I can perhaps suction it out and remove it. Again, deep suction, we go to the point of the carina. We'll feel that resistance where I can't advance the catheter anymore. We should not immediately apply suction at that point. We should remove the catheter by approximately 1 centimeter. Just a little bit. Because I don't want to hit the carina and immediately apply suction, because that's going to cause trauma to the airway at the carina level. So we hit the carina, I meet that resistance, and I pull it back just approximately 1 centimeter. And then I could start applying, when we talk about intermittent suction, as I remove that catheter from the patient's airway. That's the deep suction method. You typically see that done with adults. The shallow suction method is done in the neonatal world. Shallow suction means we're going to advance that catheter, but we're only going to put it in as far as the depth of the endotracheal tube. Not past the endotracheal tube, only to the depth of the endotracheal tube. Meaning when we're suctioning, we're really just suctioning out the tube. We're not actually getting that catheter into the child's trachea or the neonate's trachea. Reason for it, and in the neonatal world, that's been done for years. It creates and causes less trauma to the airway doing the shallow suction method. Now, if you start to look at some of the latest literature on suctioning and suctioning for an adult, there is now a school of thought to recommend, well, maybe we should do this type of suctioning to the adult patient to cause less trauma to the airway. And so there could be some places, even for the adult patient, this is how they suction at that institution or at that hospital. That's fine. That's kind of the latest and greatest. If you find, no, why are you putting the catheter, why are you stopping there with the catheter? Go all the way. Okay, well, that place they're doing the deep suction, hitting the carina. Yes, Sharon?
Do you think because the trauma to the airway makes more mucus?
Well, it
You know what I
creates
mean?
bleeding
Yeah.
and adds other stuff beyond just mucus to the airway. And you will find that, yes, when we do suction, especially repeated suctioning, there's a greater incidence of blood to appear in the sputum that we're suctioning back up. And it's really just from us and our aggressiveness sometimes when we suction. Especially this form of suctioning, because we're hitting the carina. We are hitting the trachea. We are hitting the carina.
Because I feel like you know when you take antibiotics and you get rid of all the good bacteria.
Yeah, right. You start having some GI issues, yes.
Right, or like you suction, but then you take all like the mucus that you need.
Right,
You know
right.
what I mean?
Yeah,
Does that make
yeah.
sense?
Are you talking about for like neonatal?
Or either.
Yeah.
Like when you go so deep, you know, maybe you take too much mucus and then I don't know.
To piggyback off of you, I was thinking like with something like neonatals, like if they don't have like a lot of surfactant and like a lot of like moisture.
Yeah, but
then,
remember, we're not getting that far down. We are doing deep suction, but we're
But,
not
like, if
getting to the
you have to give them
alveolus.
surfactant and stuff and you gotta like turn them all around. To,
Yeah,
like, get
but
it
that's,
back.
but now, by the time, and suctioning does matter when we've just given surfactant. We will not be suctioning for a little bit, letting that surfactant kind of work its way. But remember, the surfactant's in the alveolus. We're talking about suctioning
ET2.
airway, ET2.
Yeah.
So we still have a long way to go to get that deep or that far.
Yeah.
The deep suction, it is for the adults and the
Mhm.
pediatrics, right?
Adults,
Oh, okay.
more adults,
Okay, and then the pediatrics and the neonates are for the
more shallow. Yeah. But, and I'm waiting before suddenly the term deep suction is no longer, where everybody's just gonna be suction in the shallow method. But the literature, the research is out there. We are just a hard group. I don't mean just respiratory, but we are a hard group to change things the way we've always done it in the past. So that change really, and if you read the literature, it's probably been going on for almost 5 years now. The recommendation for everybody to do shallow suction, but it's not a universal thing where we're all doing it just yet.
No, isn't it like more beneficial, I guess, to get like the stuff out if you do deep suction?
Mhm.
Like I know it
Oh,
obviously hurts more, but it's more beneficial in the end to
Absolutely.
get everything out, right?
Absolutely, it's a catch-22.
Yeah.
Yeah.
Okay.
The added benefit, but increased risk of the trauma,
And don't you have to do it more? Wouldn't you have to?
perhaps,
do it more?
perhaps. Con-
Given that it's still kind of contested which to go with, when
Mhm.
we go to take our exam,
Yep.
is there like a preferred
Yep.
method by
Yep.
the NBRC?
Yes, and we will be covering that in due time.
Oh.
All right. And speaking of, so that was a great question by Connor. Okay, that's fine. I understand different places may do things different ways. When it all comes down to it, how are we tested on the boards?
Yeah.
And we will discuss that, and we will go over that, and where the MBRC likes to pull some of that information from. This has been an ongoing debate with the MBRC that all educators and grads have. MBRC, when you're getting some of your testing type questions, what numbers are you using? What certain procedures are you using? MBRC really holds a lot of things close to the vest. They don't share a whole lot of information as far as this is how we like to test. They will mention clinical practice guidelines, which we can always research and we can always look up and see, okay, what are the numbers that they're using or techniques that they're using and recommend. So we will definitely be going over that probably beginning a year, a little more than a year from now when we start practicing for the board exams. Because ultimately, we have to answer it the board exams way, not how they do it in this hospital or that hospital. All right, so we're applying suction. Only apply suction when withdrawing the catheter. Notice total suction time should never exceed 15 seconds. So you can't put the catheter down there, start applying suction. So what are you going to do this afternoon? What you doing? We got plans for dinner, you know? The whole time suction, no. And again, advancing the catheter, I don't count that as part of my 15 seconds. It's when you remove the catheter and applying suction that the clock starts. Now, I don't think, unless you're super slow, I don't think there should be any reason it takes longer than 15 seconds to do this. Right? Everybody see it? I'll do a little intermittent. There you go. I'll do a slow intermittent. I don't think that's any longer than 15 seconds. But there's going to be those test questions that'll say, well, how long should this procedure take maximum? You know, shouldn't last longer than 15 seconds.
We do like motion, you guys, like, do we do that, like by the boot or something?
Yeah.
That way it's scroll.
Kind of swirl, again, think of the catheter in the airway. When you do rotate the catheter a little bit, maybe you're kind of getting everything that's kind of stuck on the walls or things like that. Yeah, that's okay, that's fine. Clear the catheter. So just remember, when we do apply suction, sometimes we have to go back down again and repeat, go back down again. Because again, we may have a patient with very minimal mucus, which is fine. We cleared out the little bit they had. Or we'd have a patient with copious amounts of mucus that we're having to go down a couple different times to get rid of this stuff. And so think about how thick their mucus potentially could be and how it can kind of occlude or block up the catheter. So sometimes we do have to clear the catheter with sterile water or even saline. That's fine. I think I'll mention it. I'll mention saline a little bit more in just a second. So that's completely, if necessary. If the catheter seems kind of obstructed because of the nastiness that we just removed, we can clear that with some saline. And the last step here, step 6, reoxygenate the patient. So again, this procedure shouldn't have taken us very long anyways, but if I pre-oxygenated them for 30 to 60 seconds, took me 30 seconds total maybe to get everything set up, do the procedure, and now I'm done. Yeah, I had to go down a couple different times, so that took a grand total of 45 seconds, 60 seconds, a minute or so. Now that I'm done, doesn't hurt to go ahead and just kind of post-oxygenate them as well, for a very brief period of time. Very brief period of time. Again, maybe around a minute, less than a minute. And then if necessary, I can repeat this procedure over again for those patients that do have lots and lots of mucus. Questions?
So if you're like repeating it, you're repeating, it says steps 3 through 7, so.
Back to
but if
pre-oxygenate.
So but if you're saying like the total suction time should be less than 15 seconds, but you're saying you might have to do it multiple times, you're able to suction multiple times back to back, but then after maybe like a minute or so, it's like, okay, like let's reset for a second.
Sure, yes.
And that's whenever you would go back to step 3, but then you can still continue to do this again. And so is there like a limit as far as like
There is not.
suction time?
Total suction time for
Well,
each
what's the-
individual
No,
pull,
but total.
no more than 15 seconds. No, there's not a total, and there's not you can only place it down 3 times or anything. No, there's not a limit. There's not a limit.
But then you're just like monitoring the oxygen the whole time just to
The
make
goal
sure
is to
that-
remove secretions without causing any of the negative side effects, like decrease in the oxygen saturations, etc. All right, so things to minimize complications and adverse responses. So hypoxemia. What is hypoxemia again? Low levels of oxygen in the blood. So ways to minimize that, because again, it can occur during the procedure. Make sure we're pre-oxygenating the patient. Don't disconnect the ventilator if we don't have to. Again, we talked about open suction technique where I have to disconnect the patient from the ventilator, or the inline or closed suction technique where I don't have to disconnect the patient. Again, when I disconnect the patient, I'm disconnecting them from their oxygen. So if I can keep everything in line, then that's fine. I'm still pre-oxygenating, but less likely to lead to hypoxemia. Cardiac dysrhythmias, so stimulation of the vagus nerve. Now when we do, and here's another negative, if you will, for deep suction. When we do deep suction, we advance the catheter until we meet what? Resistance, which is hitting the carina. Guess what nerve innervates really close to the carina? The vagus nerve. You stimulate the vagus nerve, guess what happens to their blood pressure? It falls. Guess what happens to their heart rate? it falls. So there's a negative of this procedure. And so being careful that we do pay attention before we even start the procedure, what's their heart rate, what's their blood pressure look like. So during the procedure, I know if this is truly their heart rate or blood pressure falling. Cardiac dysrhythmias can be simply just from patient agitation or hypoxemia, which again, hopefully we're not causing. Hypotension or hypertension, again, from cardiac dysrhythmias. Hypoxemia, anxiety of just the procedure, the uncomfortableness the patient may be experiencing during this procedure, stress, pain, and then again, if they're coughing. I would expect the patient to cough during this procedure. Now, there's going to be times you suction a patient and they didn't cough at all. It's probably not a good sign as far as what's happening up here, right? I need a good signal that senses the irritation and the reflex to cough. So that's sometimes not a good thing when you just suction a patient and they had no response whatsoever of your procedure. But we'll get to those things in time. A brain damage, a lack of oxygen to the brain, where you know the illness that they have, with the situation that they were just encountering, they're not responding to us suctioning them. Other things, atelectasis or lung de-recruitment. Be mindful of what the vacuum or suction pressures we're using. If I sit there and set it to maximum, which I'd have to actually research, I want to say it's like 600, 700 millimeters of mercury of negative vacuum pressure if I turn that up to max. That's a lot. That's a lot. I have a video I'll share with you guys in time that shows what suctioning looks like at that high level into like a 2-liter soda bottle, and you see that 2-liter soda bottle made out of plastic just crumple and crinkle like crazy. There's that much suction. And can you imagine if it was a patient's lung, how quickly you can collapse or de-recruit the lung from such excessive pressures. Keeping duration of suctioning to less than 15 seconds, using the appropriate size catheter, and again, avoiding disconnecting the ventilator. Mucosal trauma, which we mentioned a little bit before, again, not being overly aggressive with the vacuum pressure, proper techniques, using shallow suction as opposed to the deep suctioning technique. Sorry for my abbreviations here, sometimes I get a little abbreviation happy. Suctioning. Sorry, suctioning. If you ever see something like that, John, what are you trying to tell us on that particular thing? Let me know. I just happened to glance at it and saw it. Suctioning can increase intracranial pressure. So if we have a patient where intracranial pressure elevation is a problem, we're probably going to want to limit how frequently we suction the patient. Bacterial colonization of the lower airway. Again, improper technique. More likely if I'm doing open technique suctioning as opposed to closed technique suctioning. These bullets or vials of normal saline. Okay, this is a very debatable topic in the process of suctioning. There's multiple schools of thought. I'll share them all with you guys, and you can tell me what you think would be best. All right, if we suction a patient, and I'm not really getting much out, maybe their secretions are really thick. The school of thought is, well, if I squirt some saline down the airway, that should help penetrate the mucus and kind of thin the mucus up so we can actually remove it, okay? It's why we use it, okay? The negative side is you squirt this stuff down someone's airway, down their endotracheal tube, who knows what bugs are colonizing on the inside of that tube. And what did you do with the saline? You basically just washed what was on that tube down into the lower airway. Because again, when we suction, even if I'm doing deep suction, my suctioning only starts here at the carina. If things have washed down here, well now I just introduced bacteria that was there in the endotracheal tube, and I just pushed it down to the lower lung. That's the opposition to using saline, and absolutely forbidden, don't use saline. But you're still going to find today folks that use saline routinely and folks that do not use saline whatsoever. And they're abiding by those two schools of thought, okay? I kind of fit somewhere in the middle on the fence, okay? There is a time, there is a certain situation where I would say adding a little bit, and I didn't say a lot, but a little bit of saline may help to kind of thin up, if you will, the mucus? That's another debatable topic. There's been studies that have done that said, here's mucus, here's normal saline. We put them together, guess what doesn't enter the mucus? The normal saline. What we end up suctioning out of the patient when we inserted the saline is saline. And we feel so good about ourselves because I got something out of them, okay? We feel bad when we put a suction catheter on someone's patient, we suction out and nothing comes out. Dang it, the reason I put it down there was to get stuff out. Let me squirt some saline, then up the mucus, and now, oh, there's all this stuff. Oh, that was the same saline I just put down. So I kind of sit on the fence as far as use it sometimes, but not all the time. I don't use it at all. I still will say there's a time and place, but I'm not going to know what sort of secretions the patient has the very first time I suction them. So the very first time I suction them, I'm not using saline. Let me see what I'm working with here. Let's see how thick the secretions are. And if I do need to add a little, and again, I do emphasize the word a little bit of saline. But if the secretions are coming out, great. I don't need to use this. They're thin enough.
Are there some medications that thin out?
Yes, there is. And we'll get to those medications in due time.
Could you increase the humidity?
That's another way to keep moisture and keep the secretions thinner. Absolutely. Absolutely. And those are things we're definitely going to be talking about on the humidity days and the pharmacology days.
Could you do some of the physical therapies?
Yep, and that's a bronchial hygiene day. Yes, yes, and yes. We're all getting there. Yep. No, I so much want to share every single day because there's more stuff that obviously goes with this, but I can't say it because I know that's coming in the future. So some days I really gotta keep it quiet. I just want to.
We won't tell.
In 3 days, I want to share everything there is to know about respiratory care. Any questions? Okay, great. Take your boards. It doesn't unfortunately work that way just yet. Any other questions? Sorry, don't mean that. All right, let's talk about nasotracheal suction. Everything we've mentioned really up to this point is endotracheal through the trachea. Nasotracheal suctioning. So still suctioning and getting to the lower airway, but where are we going? Through the nose. We're never going to do a lower airway suctioning through the mouth, so scratch that. But we will go through the nose. So indicated for patients who have retained secretions, they need us to suction them, but they don't have an artificial airway. They don't have an endotracheal tube, they don't have a tracheostomy tube. They look like you and me. Anybody want to sign up to be nasotracheal suction? You see what it looks like, right? You see what it looks like. Nasal passages are highly vascularized. There's lots of blood vessels running through our nose and sinus passages. What do you think one of the issues is about nasotracheal suctioning? Nose bleeding. You know, trauma to the nasal passages from aggressive respiratory therapists like us that can be slamming down the suction catheter down someone's face. Positioning of the patient, and this is a real setup picture, mind you. Usually patients are not so calm and relaxed. If they do look this calm and relaxed, I tell them cough. No, cough better. And they bring stuff up. Great, guess what I don't have to do? I don't have to suction because you have a good, strong enough cough. You can clear that on your own. So remember who these people are. These are people that can't cough. Maybe they're in a comatose state. They don't need a ventilator, but they can't cough on their own, can't cough on command, or they're not strong enough to cough.
So when you do the intubation through the nose, though, would it be a smaller tube or the same size?
Same size.
Is
Same
it the
size.
same tube, or would you have different tubes?
Same. If they're already intubated, say orally, I'm not taking that tube out and shoving it up their nose. But it'll still be the same type of tube, same size tube that can be placed there, yes. All right, so place the catheter into the larynx and trachea by placing the patient in what's known as the sniffing position. I just bought you a dozen roses. They're in front of your face right now, and think about how you're going to sniff them. Okay, and I'm holding the flowers up because everybody wants to go down to wherever the flowers are, right? No, you're sniffing position. It helps to align the mouth and pharynx and larynx kind of together. So it helps to align and kind of straighten up the trachea in line with the nasopharynx. Before we use that catheter and place it inside the patient, please lubricate the catheter. unless you really have a opposition to the patient, which I'm joking, camera, always lubricate the catheter and make sure, because I didn't put it on here, with a water-soluble lubricant. Is Vaseline considered a water-soluble lubricant? No, it's not. It's a petroleum-based. Needs to be a water-soluble lubricant. Advance until a patient coughs or resistance is felt. Again, tricky part here is not contaminating your sterile hands with the tip of their nose, or the patient grabbing your hand or grabbing the catheter as you're placing this catheter down their nose. What's known, and this is not the clearest or best picture yet, but a nasopharyngeal airway, which we'll talk about in just a second, can be placed inside the nose, the nasal passage. You'll see how far it goes in just a second. But that can be used for someone that we're going to do repeated nasotracheal suctioning. Makes it so much easier for the patient because they're not feeling the sensation of that catheter being crammed down their nose each and every time. They will feel when this pharyngeal airway gets placed, and then once it's in place, it generally can be left in there for less than 24 hours. Can be left in place. And that way, if we're coming back in every couple of hours to have to suction the patient, it's much easier to slide that catheter through the airway as opposed to having to suction it this way, each and every time. So nasopharyngeal airways would be best for someone who needs repeated nasotracheal suction. Just makes it easier on the patient. All right, sputum sampling, which we said before is one of the indications here for suctioning. When we're trying to collect sputum to see if there's microorganisms perhaps growing in there. Please remember that if the patient has a strong enough cough on their own and can bring up their own mucus, then I don't hand them this, but I hand them their own specimen cup and say, I need you to cough nice and deep from the lungs, and don't clear your sinuses, buddy, from the lung, because we want to see what maybe type of pneumonia you have. I need a good strong cough here from the lungs, good diaphragmatic breathing, good cough effort, and whatever you bring up, expectorate into that cup. We'll close it up, we'll label it, we'll hand it to the nurse. Nurses always love to take that from us, right? But that's great. I didn't have to suction them. But if the patient is not capable of suctioning, or not capable of coughing and expectorating up, then we can go down with the suction catheter and actually get our own sample for us. Maintaining sterile technique, of course. So this is suctioning just like we normally would suction, but the only thing we're going to be doing different is adding this in line with the suction catheter. So here normally, and at least in previous pictures, here's my collection tubing, my vacuum tubing connected to my catheter. And I can go down and suction the patient and do whatever I need to do. With this specimen trap, also known as a Lucan's trap, that could be placed in between. So when I do suction the patient and stuff comes up, it stays in here and doesn't go back to the wall and the collection canister, the nasty collection canister that's there on the wall. Who empties out that nasty canister? Nurses. Yeah, it's not us. It's not us. It's not us. Okay. Let's move on to some other stuff here. Okay. I feel like I'll need a spin when that one goes up. Okay. So talking about some different artificial airways, routes of artificial airway placement. A pharyngeal airway. Pharyngeal airways only extended to the pharynx. Again, we have naso, oro, laryngeal, pharynx, but only go as far as the pharynx. Pharyngeal airways do not enter the trachea. Remember that. Pharyngeal airways do not go that far down. They do not enter the trachea. Tracheal airways, like your endotracheal tube or tracheostomy tube, do end up in the trachea. So make sure you know what we're working with here. Endotracheal tubes, again, those that are placed down into the trachea, can be placed through the mouth or nose. And we'll go over that process here a little bit more in due time. All right, the nasopharyngeal airway. That's what we talked about before when we talked about repeated nasotracheal suctioning. Nasopharyngeal airway. So minimizes that trauma of the suction catheter. Again, this still has to be placed, so I will say this is probably not the most pleasant experience for a patient to have this placed, but we still will lubricate the end of this airway and place it into the patient. Oropharyngeal airway is inserted into the mouth over the tongue. Keeps the tongue from backing up and obstructing the oropharynx, keeping the airway open. I will point out, and I meant to put this in bold, so do it yourself or highlight it or whatever. Oropharyngeal airway. So here's our two examples: nasopharyngeal, oropharyngeal. Oropharyngeal airways are only going to be used on an unconscious patient. Because if you put this into a conscious patient, what are they going to do? They're going to, aside from rip it out, they're probably going to gag.
Cough it out.
What if they can't cough it out? Vomit and aspirate. Again, and you'll see how far it goes. You think this is just not between the teeth. This goes way past the tongue, not to the trachea, but way past the tongue, because it keeps the tongue pulled forward, away from the back of the pharynx. All right, this picture I stole from your textbook. The one on the far left, is a nasopharyngeal airway. These do come in a clear color as well. These two are different types of oropharyngeal airways. Again, pretty good size. Remember, your tongue's going to be back here, keeping it from falling over the back of the oropharynx. I like this picture and the next one that's going to come up, so you can really see how far. So here's your nasopharyngeal airway inserted, and again, you see where its placement. Does it end up in the trachea? Not even close. Not even close to the trachea. But again, it does allow an opportunity for our suction catheter to get down. Again, if you had to pick one of the two, you had to have one of these, you're going to rather pick this one as opposed to the oropharyngeal airway. Notice where its location is. Again, it's preventing the tongue from falling over the back of the oropharynx. Notice this picture represents insertion. When it's inserted backwards. It's inserted backwards. So notice the curvature here. Let's say the curve is this way. We place it in, passing the hard and soft palate. We do a 180-degree turn to put it into position. If you were to take this, and notice the curvature, and just place it straight, you're more than likely going to grab the tongue and force the tongue in the back of the oropharynx, which is what we are trying not to have done here. Conscious patient or unconscious patient? Unconscious patient, please.
Please not.
Right, because because that would elicit a gag reflex.
Punch.
Or a punch, right? There you go. There you go.
Professor, we actually saw one
Gotcha.
patient.
Yeah. Was the patient? I'm guessing.
Well, they were unconscious, and then they woke up in pain, and then started.
And had that in the ear.
Yeah, and then they started pulling on it.
Yeah, a very uncomfortable thing to have placed. Absolutely. Sizing. Okay, they do come in different sizes. So how do you know what to pick? Well, depending on which form, oral or nasopharyngeal airway. If it's the oropharyngeal airway, from the incisors, the teeth, down to the angle of the jaw. So you could literally, I didn't bring one today, but you could literally hold it up against the patient, right? To see, that size is a little too small, or no, this one's way too big, to find what size works best for your patient. The nasopharyngeal airway, and again, it has a natural curve to it, but from the tip of the nose to the earlobe, that's the approximate distance you're trying to sit there and measure, okay? Some are going to be a lot longer. Okay, that one's too long for that patient. Some could be shorter. Okay, that's too short for that patient. So pretty simple sizing here when you're going to use this for a patient. All right, tracheal airways. This is kind of the last part of this today. So tracheal airways. These are airways that end up in the trachea. Airways that end up in the trachea. So the endotracheal tube inserted through either the nose or mouth, through the larynx and into the trachea. Patients could be orotracheally intubated, meaning through the mouth, or nasotracheally intubated, meaning it's going through the nose. Tracheostomy tubes, again, surgical incision there in the neck. But let's talk about the endotracheal tube. Because of all these emergent type airways, endotracheal tube is going to be the one we're definitely going to be encountering most often, most frequently, especially early on in school. And again, maybe not so much this semester clinically, but in time you will. So this is an endotracheal tube. A lot of it is labeled already, which I appreciate that you have the ability to kind of understand and see where things are, but let's kind of go over this. So this is what's going to be exposed on the outside of the patient. This is going to be inside the patient, inside their trachea. This is going to be what's exposed. This is what we're going to see. So this 15mm adapter will connect to our resuscitation bag. It will connect to our ventilator circuitry. Okay, so that's how the patient's going to be breathing. Let me start down here. It's going to have a beveled tip on the end, so kind of an angled tip. Part of this is so when it's being inserted, it causes less damage, less trauma during the insertion. Just up from the tip, there's a Murphy eye. It's called a Murphy eye. It's a little hole here on the side of the tube. On the side of the tube, not the main channel, but on the side of the tube. The purpose of the Murphy eye is if this main channel gets blocked or obstructed, maybe even mucus plug. Is there still a way for the patient to pass air back and forth? Yes, and it would be through that Murphy eye. There's going to be a cuff that's going to help to seal that endotracheal tube in the airway. So it's going to be filled with air. Well, how does air get in there? Through the pilot balloon. So we will add air to the pilot balloon. The air will go down and inflate this cuff.
So I've heard some of the therapists at my work say that this is a closed circuit. Is that how it becomes a closed circuit? Is from that cuff? Like, it's like sealed?
Not in that respect. That's not what they're referring to it as. It's just because everything is enclosed. But that's going to add air to the cuff, which will help seal it into the airway. Okay, so no air is going to leak back out through the mouth. Air is only going to come in and out through this tube. There's a radio opaque line on the tube itself. Purpose of the radio opaque line is when the tube gets properly placed or gets placed, it will show up on the x-ray. You can see that radio opaque line on x-ray, because without it, you wouldn't be able to see the endotracheal tube on a traditional, typical chest x-ray. But the line's there to make sure we're in the right spot, the right position. And then the tube length markings here on the side. Again, these are all in centimeters, representing distance from this end, the end that's inside the patient. So when you notice, you walk in to check on a patient, you find their tube is positioned at their incisors, at their teeth at 23 centimeters. This morning, because you were part of the team that put that tube in, later this afternoon you show up and you find it's at 18. What direction is the tube going? Out. It's on its way out. Or we put it, what did I say, 23? We put it at 23. Later in the day you come in and it's at 27. You know it's going further down. Okay? So when we place it at 23, we need to keep it at 23 and make sure it stays at 23. Or whatever location the tube was supposed to be.
How do you monitor, how do you know how much you inflate the cuff?
We'll get there. We'll get there. I don't remember if this is a cheat. No, I'll talk more about that next week. But I will share something with you guys regarding that. So the next few slides are just kind of little close-up views of some of the things we just mentioned. There's the Murphy eye. You can see that beveled tip being occluded by this person's finger. Again, this would be the only way gas could flow back and forth from the patient. The centimeter markings that are here, do not reuse. It's disposable, single patient use, please. But the centimeter markings. There's the pilot balloon, pilot line. We know this when we add air to this with a syringe, that will inflate the, which I didn't put a picture here, the cuff, right? As far as kind of alluding a little bit to how much, anybody tell how many cc's or mLs this syringe is? 10. That's not a very big syringe. And it doesn't take a big syringe to add air to that cuff. Now I can get a 60 ml syringe. If I was to put all 60 mLs in that pilot balloon, what's going to happen to my cuff? it's gonna pop because it can't handle that much air. So always remember, let's start with 10 mLs or 10 cc's, ml/cc, same thing. Start with 10, we'll add just enough air to help to seal it into the trachea. We'll get to talk about measuring pressures of that later, okay? That's coming up next week. And so we will be monitoring pressures inside that cuff. But again, I don't want to overinflate the cuff, and at the same time, I don't want to underinflate it. Because if I underinflate it, guess what? Air is going to leak from around the outside of the cuff, or outside of the tube, and not go back and forth through this tube. One more here. Okay, so again, one more time. Centimeter markings line, but you'll also notice it's written in a couple different places on this tube. Some further down the tube, sometimes some up on the tube, sometimes even on the adapter itself. This is where we get tube size from. So you'll notice a number here, 6.5. That is the ID, internal diameter of this endotracheal tube. This 8.9 represents the OD, or outer diameter. Now remember when we were talking about suction catheters and making sure the suction catheter size wasn't too large? How do I know the size of the tube? It's the internal diameter is the number I'm focusing on. Internal diameter in millimeters. Again, there is some thickness, I guess, to these PVC type material tubes. Maybe not as dramatic as a zoomed in view, but knowing the internal diameter is what we're using for our suction catheter. It's fine to know the outer diameter, but that really has no bearing on my suction catheter. When we choose a tube, okay, when I have a patient in front of us and I know they need an endotracheal tube, and I'm trying to decide, well, I have all these different sized tubes, okay? What size does this patient need? Now we'll talk about what normal sizes are for a variety of patient populations. But when you pick a size, when you choose a size, and you will know what is a normal adult size as opposed to pediatric sizes, so don't worry about that. When you're deciding, because it's just more than just a single number. There's some various sizes for adult females, different sizes for adult males. When you're deciding, well, do I pick the one on the low end of the scale or the high end of the scale, or really does it matter, okay? When we're selecting the tube size, and again, tube size represents not the length of the tube, but the diameter, the width of the tube. The smaller the tube, the smaller the size tube, the easier it's going to be to place the tube. Easier it's going to be to place that tube. So less traumatic for the patient because the tube diameter is a little bit smaller. The other end of the spectrum, if I say, no, I'm going to pick a tube that's on the larger side, again, still normal range for this patient, but I'm going to pick one that's larger, meaning it's going to be a greater diameter, but what happens for ease of insertion? It's going to be a little more challenging because the tube's bigger in diameter. And you may think, going from this to this is not that much. Trust me, when you see the size of the airway, it could make a huge difference. The larger the tube, the more difficult, more challenging it's going to be to place. But here's the benefit. If you're putting a breathing tube in someone's airway and the diameter is wider here, larger here, guess what it's going to make their breathing? Easier. It's going to create less resistance. The smaller the tube, the greater the resistance, just like we talked about the other day. All right, so ends of the spectrum there. Do I want to pick one that's larger or want to pick one that's smaller? Well, what's my purpose? If this patient, it's very challenging to get the tube in because of the patient's size and anatomy and things like that, well, maybe I need to err a little on the smaller side. If putting the tube looks pretty easy based on the patient's airway and I want to minimize airway resistance, then pick one that's at the larger end of the spectrum. So, from here, regarding sizing, okay, generally a woman's intubated with a 7 or 7.5 endotracheal tube, where a man's intubated with 8 to 8.5 endotracheal tube. Now that's more by the book. I will say this, sometimes you see folks be intubated with tubes that are a little on the smaller side, little on the smaller side, even for guys, a little on the smaller side, and you could say, you know, that's kind of normal size for a 5'6" petite female, not this guy who's 6'4", 250 pounds. Again, that's the general ranges you're going to see here. Oh, one more thing, I forgot I had this slide here at the end. What's the pilot balloon or pilot line for?
To show up on X-ray.
No. To inflate the cuff, to use a syringe to add air to the cuff. The tube cuff then, now that it's added with air, helps to seal it into the airway. I didn't mean hold it in the airway, but seal itself into the airway. The radio opaque line for the X-ray, centimeter markings, tube depth, how far in it is, or maybe how far out it is. The Murphy eye,
So
that second passageway option, which I never hope that happens to my patient, but that's the only way they can breathe, because I don't want to keep the end of that tube obstructed. But that's why we suction, right? That's why I suction, and I'll know if it's obstructed, because I'll immediately hit resistance, and I know I haven't put that tube as far down as the carina. Internal diameter, outer diameter of the tube. When we truly say this is a size 7.5, which one is it? Is that ID or OD? ID, the internal diameter. And then speaking of appropriate sizes. So here you go. Tube sizes. Endotracheal tube sizes based on patient population, who they are. Now you can fast forward and look at the bottom, men versus women, and you can see what the textbook says. Female 7.5 to 8, men 8 to 9. Those are awfully large sizes for an adult patient, male or female. I think the previous slide that said women 7, 7.5, men 8, 8.5 is a little more realistic, I think, from what you would see. But I just wanted to share this. Not that I'm expecting you to memorize this entire chart, right? I would say, I would know that when I ask the question. And again, the difference is male versus female, adult. But I just wanted to share that, boy, there's all kinds of sizes, and notice some of them are not that far in age. But those are the sizes, again, all internal diameters. In due time, we'll also talk about this. How far? Again, we talked about the centimeter markings and determine depth. But look at the different depth levels for the various age populations. So you can see kind of here for the adult patient what those centimeter marking depths would be. And again, the depths are from the end of this endotracheal tube to the mark here at the patient incisor. Okay? For a woman, that depth generally from 19 to 21 centimeters. For a man, 21 to 23 centimeters. So when the tube is placed, that's a good idea to know that it's gone the proper depth. Jeremy?
So for the proper depth of the tip of the tube, is that like right above the carina, or is it quite a bit above it?
From the end of the
Right.
endotracheal tube.
Okay.
Carina is going to be down
Okay.
here somewhere.
So
right?
can you like approximate how far the carina is depending on a patient, like what size they are? That way you can kind of like predict.
Somewhat, but my prediction is not going to have any value. And we'll get to this more next week. One of the last things we do after a tube's been placed is get the chest x-ray. And with that radio opaque line, I'll see exactly where the tip of the tube is, and I'll be able to compare it to where the carina is and determine what that distance, what's the depth is. If I'm too close, we'll know, hey, we need to pull that tube back. Or no, the tube's in the right spot. Or maybe the tube is up too high, it's almost on its way out, and we need to advance it more. But that's kind of that final step of this tube being placed, is the chest x-ray. Is there another question? No? You guys tired?
Yes.
Long day? It's okay, I got like 50 more slides to go here. Just kidding. All right, so my questions for you guys. 7, 8, 9, several questions here. All right, so first question. It's a long chapter. This is just part 1.
Yeah.
Stop it.
Set the mood.
People can come
Is that my walk-up song? It's supposed to be the beginning of class, not the end. All right. How often should patients be suctioned? At least once every 2 to 3 hours, whenever they're moved or ambulated, when physical findings support the need, or whenever the charge nurse requests it.
C.
Well, we want to be welcomed, right? So, no, it is C. C is the correct answer. C is the correct answer for this one. Physical findings support the need.
If it gets to the charge nurse, then you're in trouble.
Right. But they're not my boss. I do have a different person I'm reporting to.
They can talk to your boss.
That's right. They're good. They could make our lives miserable. All right. So this one was C. Everybody okay with that one? Can we do a question?
Can only we suction or can the nurse?
The nurse can suction too. The physician can suction. So sometimes that's a good point. I'm glad you brought that up. I know I've suctioned this patient once today, early this morning, and probably 20 minutes after I walked out of the room, the nurse came in the room. He or she probably suctioned the patient too. The doctor comes in the room 30 minutes later. He or she may suction the patient. I show back up 4 hours from the time I originally saw the patient. Let me suction them again. Just so you can see how potentially often a patient could be suctioned. And again, not on any sort of routine schedule, it just everybody wants to do their part, but I would say this for the respiratory therapist. If the physician did not suction, and they say, where's RT today? Oh, RT's right over here. And the doc comes up to me, again, this is toward the beginning of my shift, but I've been there 2 or 3 hours already, and the doctor comes up and says, how is so-and-so's secretions? I don't want to look like the, I don't know, aren't you the RT? Shouldn't you be aware of patient secretions and quantity or consistency of them? So yes, I will always suction in the beginning of my shift, just so I kind of know what I'm working with. And I can communicate with the nurse going, I just finished suctioning him and got such and such out, so no need for you to have to suction him right now, or vice versa. The nurse beats us in there, and here's the patient drowning in their secretions. Of course they're going to suction, and they may let me know, hey, I just suctioned him, he had a whole lot of stuff, but I cleaned him out. Okay, great. Again, just communication between all team members.
You answered my question.
Okay.
I have a question. So
No, that's enough.
so obviously we're like nurses and PCTs, they chart, you know, eyes and nose and things, or, you know, secretion. But like for a respiratory therapist,
Yep.
when we do suction,
We still chart.
are we
secretions.
charting, but is it, I've not seen where it's been like being measured, like a cup or whatever. I mean, like if we do a sample.
Copious amount, scant
Okay,
amount.
so it's just based on visual.
So instead of me saying it's approximately 2,
Alright.
scan amount meaning very small, copious, it was a lot. Do I have a middle of the spectrum word I could use? Not scant, not
Moderate.
copious.
Moderate amount.
Yeah, I like that. Moderate. Moderate amount of pale yellow secretions.
Plus, you can't always go by what's in the canister, because like there could be.
Yeah, absolutely. And I'm never looking at cancer anyways, because it's disgusting and
Yeah.
gross, right? Who knows the different parts and pieces of fluids that ended up in that canister? Right? Not to be disgusting. All right, next question. Can you use an oropharyngeal airway on a conscious patient? True or false? I guess technically you can. You're not going to like the result, and the patient's not going to like it. Maybe I should have worded this, should you use an oropharyngeal airway on a conscious patient? Absolutely not. Absolutely not. Nasopharyngeal airway? That's the airway for a conscious patient. Oropharyngeal airway, unconscious.
It's good for interrogation.
Yeah, not comfortable. And like I said, this Friday, you guys will get to see how pliable a nasopharyngeal airway is and how rigid an oropharyngeal airway is. There's no give, there's no play with it. When suctioning a patient, the total suction time should not exceed 10, 15, 30, or 60 seconds. Should not exceed 15 seconds. Very good. I will say this, there's going to be a time we'll talk about next week that is different than that, and that's going to be the confusing part. And there's going to be 2 different times that's going to be stuck in your head, and you're going to be like, am I supposed to use it this one or for this one? So just 15 seconds seems pretty straightforward right now, because that's the only times we've talked about, aside from maybe pre-oxygenating. But there's going to be something else that's a time piece that'll be next week, and it's easy to get them confused. In adults, the external diameter of a suction catheter should not be larger than what percentage of the internal diameter of the endotracheal tube? Is that 10%, 25%, 50%, or 70%? 50. And you know how I can change this question? Replace the word adult with a neonate, and we have a new answer, right? So even though I didn't give that question, make sure you are still comfortable with it. Question?
Would it be 70 for? Okay.
Correct. If it was a neonate, the answer then would be 70%. All right, I think this is my second to the last question. What size suction catheter would be needed to suction a patient with a 6.0 endotracheal tube? So what's the what's the calculation? I was going to say shortcut, I guess it's not shortcut. To convert this millimeters, 6.0, that's millimeters, to convert it to French, what do you do? Times 3. So 6 times 3 is 18. And you know what on the test?
You would need to know.
18 is going to be an answer, right? 18 French suction catheter, which is like a garden hose. I'm a little bit exaggerating a little bit, not so much. 18 is going to be an answer option, but what do you do with this 18? Divide it by 2, which gives you 9 French, or you can take 18 and multiply it by 0.50, which gives you an answer of also the same, right? Jeremy.
Questions and complaints.
For an adult.
You should emphasize if it's for
Or
an adult or
for-
for a neonate.
Well, we wouldn't be intubating a neonate with a 6.0 endotracheal tube.
Some big babies though.
I'm just teasing. I'll make sure it's written better than this one. All right. So we said the answer was then B, 9 French. And my final question. You ready for your picture?
There's my friend.
Yeah, you're starting to know me now. Okay. So yes, there is a lab this Friday. So everything we talked about today. Suctioning, suction catheters, the open, the closed, the airways, oropharyngeal, nasopharyngeal, endotracheal tubes. We'll be working with and playing with this Friday. Okay? Any questions before I let you guys run? Nope. All right. It is 1:36. You don't have to go home, but you can't stay here. See everybody.